Good morning, everyone. I am Prajwal Vaman Ghatul. I am currently pursuing Doctor of Pharmacy. Today, we are going to conduct a session on sulfonamides. We will discuss the pharmacology of sulfonamides. So, what are we going to discuss today? We will learn about the introduction, the classification of sulfonamides, mechanism of action, bacterial resistance to sulfonamides, pharmacokinetics of sulfonamides, adverse effects, drug interactions, and the therapeutic uses of sulfonamides. So, the introduction. Sulfonamides were the first effective antimicrobial agents that were used in the treatment of bacterial infection in humans. They are the derivatives of sulfanilamide, which is para-aminobenzoic sulfonamide, and they are synthetic compounds. The basic structure of sulfonamide: a free amino group in the para position is required for the antimicrobial activity of sulfonamides. Sulfonamides were produced and used extensively in the subsequent years, but because of rapid emergence of bacterial resistance and availability of many safer and more effective antibiotics, they are currently used only in combination with trimethoprim as cotrimoxazole or with pyrimethamide. Classification of sulfonamides. Sulfonamides include systemic acting agents, local acting agents, and others. The systemic acting include short acting agents like sulfadiazine, intermediate acting drugs like sulfamethoxazole, and long acting drugs like sulfadoxine. The local acting agents are sulfacetamide, silver sulfadiazine, and mefenide. Other drugs include sulfasalazine, which acts as both locally and systemically. Mechanism of action of sulfonamides. The main motive and the action of sulfonamide is to inhibit the folic acid synthesis. Para-aminobenzoic acid is the precursor of folic acid, which is essential for the growth and multiplication of many bacteria. Sulfonamides, being structurally similar to PABA, competitively inhibit folate synthesis enzyme and prevent the formation of folic acid, thereby producing bacteriostatic effect. They are not effective in the presence of pus as it is rich in PABA, purines, and thymidine. Mammalian cells do not synthesize folic acid but utilize folic acid in diet, hence are unaffected by sulfonamides. Here in this pictorial diagram you can see that sulfonamides inhibit folate synthase, thus this inhibits this step and tetrahydrofolic acid is not formed. Today there are many bacteria that shows resistance to sulfonamides. This resistance to the sulfonamides is developed due to decreased affinity of folate synthetase for the drug, efflux of the drugs by the bacteria, and development of alternate metabolic pathway for folate synthesis. Sensitivity patterns have changed depending on the extent of use. When a microorganism is resistant to one sulfonamide, it is resistant to all of them. No cross resistance have been found between sulfonamides and any other antimicrobial agents. Development of resistance has markedly limited the clinical usefulness of this class of compounds. Pharmacokinetics of sulfonamides. All systemic acting sulfonamides are well absorbed from the gut. They are bound to plasma proteins, particularly albumin. Sulfonamides are distributed in almost all tissues of the body, including cerebrospinal fluid. They cross placental barrier and reach fetal circulation. They are metabolized in liver mainly by acetylation. The acetylated products have no antibacterial activity but retain the toxic potential of the parent compound. Sulfonamides are excreted partially unchanged and partially as metabolic products. Sulfamethoxazole has intermediate duration of action because of its slower oral absorption and urinary excretion. The half-life in adults of sulfamethoxazole averages 10 hours and it is preferred compound for combining with trimethoprim because the half-life of both the compounds is similar. Sulfadoxime and sulfamethopyrazine are ultra-long-acting compounds which acts more than 1 week because of its high plasma protein binding and slow renal excretion. The half-life is approximately 5 to 9 days. They attain low plasma concentration and are not suitable for treatment of acute pyogenic infections, but are used in combination with pyrimethamine in the treatment of malaria. Now let's discuss the adverse effects of sulfonamides. The acetylated products of sulfonamides are poorly soluble in acidic urine and may cause crystalluria, hematuria, or even obstruction of urinary tract. This may be avoided by taking plenty of water and alkalizing the urine. Hyposensitivity reactions include skin rashes, itching, drug fever, and exfoliative dermatitis. Stevens-Johnson syndrome is the most severe type of hypersensitivity reaction characterized by fever, erythema, multiforme, and ulceration of mucous membranes. In patients with glucose 6-phosphate dehydrogenase deficiency, sulfonamides may cause acute hemolytic anemia. They rarely cause hepatitis and suppression of bone marrow. Uses of sulfonamides in neonates, especially in premature babies, may cause displacement of bilirubin from plasma proteins. The free bilirubin can cross the blood-brain barrier and get deposited in the basal ganglia, resulting in kernicterus. Drug interactions of sulfonamide. Sulfonamides potentiate the effect of phenytoin, methotrexate, oral anticoagulants, and oral hypoglycemic agents like sulfonylureas by inhibiting their metabolism and displacing them from plasma protein binding sites. Therapeutic uses of sulfonamides. Sulfonamides alone are rarely used now for systemic infections. They are used in combinations with other antimicrobial agents. Sulfadoxime and pyrimethamine are used in combination with artesunate in the treatment of chloroquine-resistant Plasmodium falciparum malaria. Sulfadiazine and pyrimethamine combination is the drug of choice for toxoplasmosis. In nocardiosis, sulfamethoxazole in combination with trimethoprim is used. This combination is also used in the treatment of pneumocystis jirovecii infection in the patients with AIDS. Sodium salt of sulfacetamide is used exclusively for the treatment of ophthalmic infections. It is administered as eye drops or eye ointment. It is preferred because of high aqueous solubility, neutral pH and non-irritating nature of the drug, good penetrability on topical administration, low incidence of hypersensitivity reactions, and low cost. Silver sulfadiazine and mefenide are used topically for preventing infection of burn wound. Silver sulfadiazine slowly releases silver ions which are toxic to the microorganisms. It is not effective in the presence of pus and tissue fluid. Sulfasalazine is used in the treatment of inflammatory bowel disease and rheumatoid arthritis. In the case of rheumatoid fever, sulfadiazine can be used for prophylaxis of rheumatoid fever. Thank you everyone for listening. I hope you liked the session, you learned something new from it, and you understood it. If you liked the video, please share it with your friends and spread knowledge. Thank you.